Merci Guillaume et bonjour à tous. Merci pour l'invitation à revenir à Lyon. I'm going to speak this morning about risk factors for ACL graft failure, some data from the MOON cohort. So I would first love to thank all of the MOON centers and contributing surgeons without whom none of this work can be done, and especially all the faculty and staff who support us at all these institutions to gather all of this data. So as we've seen so far in this meeting, results vary following ACL reconstruction, and there are certainly numerous factors that affect the outcomes of ACLs, particularly those that can influence failure. These include patient, injury, surgical, and postoperative factors. My goals in this talk are to quantify ACL revision risk, identify factors that influence this risk of ACL graft rupture, and then talk a little bit about contralateral injury, all from the MOON database perspective. So the data from the MOON cohort was collected at 7 centers across the U.S. Over 3,000 ACL reconstructions were prospectively enrolled and followed prospectively for graft failure as well as patient-reported outcomes. It's important to remember that in this database, graft failure is defined as a revision surgery, so there may be some underestimate of the true failure risk. Overall, in the MOON cohort, there were 3,276 patients enrolled between 2002 and 2008. The median age was 23 years. We had follow-up available for failure, or that is to say revision surgery, in approximately 3,000 of these patients, 91%. And you can see the rates of patient-reported outcome completion below. So we looked first at the 2-year predictors of failure. And the things that really jumped out here in the early evaluations were age and activity level. As we've seen several presenters describe, these really are the major drivers of early failure risk. Another factor we looked into as a predictor of early failure risk is high-grade knee laxity. We defined this as having a Lockman greater than 10 millimeters, an anterior drawer greater than 10 millimeters, or an explosive or 3+ pivot shift. And you can see that the 3+ pivot shift was really the driver of this high-grade laxity group, being present in over 80%. When we looked at these patients at 2 years, we saw that the revision risk was substantially higher in the high-grade laxity group than the group without high-grade laxity, with an odds ratio of nearly 2, controlling for some other factors that were thought to predict revision. Graft choice was also an important predictor at 2 years, particularly allograft, where we can see that this predicted early failure. We didn't have enough power at this point to compare autograft choices, as you can see, but it's interesting to note that the allograft effect is not across the board. We really see that in these younger patients, particularly those under 20, is where we really see the high risk of allograft failure, and therefore do not recommend allograft in this population. We were underpowered still, I said again here, to look at autograft choice. So we followed these patients longer. Out to 6-year follow-up, we had follow-up on 2,999 of these patients, 91%, and we found failures, again, within 6 years of surgery at 7.5%. And you can see the distribution here, where roughly half occurred before and after the 2-year mark. Interestingly, the median age again here is 23 years. So we chose to focus more on the younger cohort, looking at these patients who are under 22 for the most part, participating in twisting and pivoting sports daily. We had 839 patients who met this criteria, a median age of 17 years, and we had a good distribution of patellar tendon and hamstrings here, but again, important to note, no extra-articular procedures were performed. If we look at these groups, the overall failure risk was 9%. We see age was a significant predictor. Even in this younger cohort, those under 17 were substantially more likely to fail than those between 17 and 22. Again, the high-grade laxity really jumps out here as a big predictor of failure. And then graft choice does become significant here, where we can see a substantially higher failure risk of hamstring autograft in this population. We developed a risk calculator to really try to quantify risk and give each individual patient an estimate of their risk with each graft type. This can be accessed online, and you can see here an example where we have a 18-year-old soccer player with a high marked activity score, twisting and pivoting up to greater than 4 times a week. And if we put her data into the calculator, you can see what this spits out for us is the risk of re-tear based on graft choice, hamstring or patellar tendon, and whether or not they have high-grade laxity. And this, I think, is an interesting data point that you can share with the patients. In particular, I think what often jumps out here is the very high risk of isolated hamstring autograft in this population. As multiple presenters have described, this is probably not the recommended treatment strategy today, again, in the absence of a lateral procedure. Contralateral injury risk is interesting. In the same population, we do see a higher risk of the contralateral injury in the setting of a hamstring reconstruction. And the biggest predictor of that was sports. So playing a sport other than basketball, football, or soccer substantially reduced that risk. So we think this really is an exposure issue. Age, again, was a mild predictor of contralateral risk. Graft choice, again, a mild predictor, maybe slightly lower in the hamstrings. Interesting, though, the high-grade laxity was not at all a predictor of contralateral injury. This is important, and I think this suggests that this is a bit of a different predictor than the other two. It certainly affects graft tear risk, but not contralateral injury risk. And what this suggests is that high-grade laxity is much more of an injury factor than a patient factor, and really does support the use of adjunct procedures in this population, be that LET, ALL, or potentially other options. So the total second injury risk you can see quantified, both contralateral and revision risk here, is up to 20%. And interestingly, that distribution is a bit different between patellar tendon and hamstring. So you could sort of think that if you did a patellar tendon, maybe there's a little higher risk of a contralateral injury, and with a hamstring, a little higher risk of an ipsilateral or of a graft tear, So that begs the question, which of these maybe would you rather have? Which is worse, if you will? So we decided to look at that question in our cohort as well. We had, again, 2,333 primary ACL reconstructions, and we identified 267 of these who had a subsequent ACL injury within 5 years. This included 124 who had revision ACL reconstruction and 132 with contralateral injuries, and we excluded those unfortunate 11 who had both. We then followed these patients out to the 6-year time point after their primary ACL reconstruction and compared their patient-reported outcomes to determine which, in fact, was the worst second injury to have. This, again, was minimum 1-year follow-up from their second ACL surgery, and then we utilized regression analysis to compare patient-reported outcomes between these two groups. What we found was that the revisions were more likely to happen earlier than the contralateral injuries, 1.3 versus 2 years, and we found 87% had completed PROs in this population. This is a mean of 4.5 years after the second injury, and again, a minimum of 1 year. And what we find here is that across the board, those who undergo a revision ACL reconstruction report substantially poorer patient-reported outcomes than those who have a contralateral injury, and this effect carries on even after you control for multiple other factors that can affect patient-reported outcomes, including meniscus status, high-grade laxity, and articular cartilage and meniscus status at the time of the original surgery. So in conclusion, ACL graft tear and contralateral risk remain high following ACL reconstruction, particularly in the absence of lateral procedures, and having a graft tear is worse than a contralateral injury. Age, activity level, and high-grade knee laxity are the strongest predictor of ACL graft tear and revision. Sport played, that is to say exposure, is the strongest predictor of contralateral injury risk, and graft choice should be tailored to patient needs and preferences, but probably avoiding allografts and particularly isolated hamstrings without lateral procedures in those young, active patients. Here's our funding. I'd like to thank those who supported this work, and thank you very much for your attention.